Okay, so this is going to be over chapter 29 in your Fundamentals of Nursing book. It's on vital signs, which is part of your assessment, right? Measuring vital signs is your responsibility. Now, of course, we have, the hospital will have CNAs, we'll have or maybe LPNs that will help us with vital signs. But ultimately, it's your patient, it's your responsibility. You need to make sure you clean each device between patients. You don't want to transfer germs from one patient to another. Make sure your equipment's working properly. Make sure you have the appropriate equipment. And know their usual range of vital signs. Always use a systematic approach. Verify, communicate any changes, and talk to your patient. Let your patient know what you're doing and provide teaching. Body temperature is one of the first things we do is take people's temperature. Excuse me, you should have learned a lot about the temperature in anatomy physiology. Hypothermia, hypo, medical terminology word means below or low. Anything hypo is low. Hyper is high or fast. Kind of think about it as like hyperactive. Think about hyperactivity. That means that they have a lot of activity. A lot of activity. They're fast. Hypoactivity would be someone very doesn't really move much. So hypo and hyper, those are two med term words you need to know. Thermia, of course, also means heat. So hypothermic means low. Hyperthermic is high. So you want somebody to have their temperature right in the average range. 98.6 is considered the average. That not everybody's 98.6. Matter of fact, you'll find a lot of people in the 97 range. Remember, 98.6 is the average. Different things affect body temperature. It could be age, exercise, their hormones, circadian rhythm, stress, environment. Could even be if it's here in Florida, 105 degrees outside, their temperature is not going to be low. They're probably going to have a little bit higher temperature. Temperature alterations could be caused by fever, by hyperthermia. Remember, that's too hot. Heat stroke, heat exhaustion, or hypothermia, which would be their temperature would be too low. Here kind of shows some different things like with you have a fever. That's when you start having the vasoconstriction. You can have the shivering and chills. That's you see that with people that are very, very ill. They start having chills. So you want to do your assessment. You can there's different types of thermometers. You have, the good old-fashioned mercury thermometers. You rarely see those anymore. You have electronic thermometers. You have a chemical dot thermometer. Here's some examples of different ones. You'll see the electronic thermometer. That's the one we're used to seeing quite often in a healthcare facility. Tympanic is in the ear. Temporal, we're seeing more of those, more temporal. Chemical dot disposable is just you stick it on. That's good if you're in a pinch, but they're not as accurate. Always want to assess for any kind of impaired thermoregulation, hyperthermia, fever, or chronic fever. Part of the nursing process, that's where you have your planning and your implementation and your evaluation. Let's skip over that for now. Okay, I guess we're on to pulse. So temperature, yeah, I mean that's usually pretty easy. You want to check somebody's temperature. Obviously, if you're doing it orally, you want to ask them if they've had anything cold to drink. Sometimes people drink, and have a nice sip of ice water, and then you come in and want to take their temperature, and now it either doesn't register or it's very low. So be aware. Or they could have had something very hot to drink and now it's showing that their temperature's elevated, but it's not true. So be aware of those things when you're taking someone's temperature. Pulse. When we check pulse, if you check it peripherally, you want to check both at the same time. Um, like if you want to do the radial artery and you want to check both at the same time because part of this is to compare one arm to the other. You want to see how the pulses are. If they're you can feel the blood flow in the artery. You can feel the palpable bounding. Um, it's going to originates from the SA node in the heart. Okay, that's nice. Okay, here we go. You can use a stethoscope. That's usually for like your apical pulse, which is on your chest. You want to use your stethoscope to get the apical pulse. We'll practice that in lab. See, there's the apical there. Well, they're getting a pulse there. Rate, rhythm. When you're doing a pulse, you want to look at the rate. How fast is it? How fast is the pulse? What's the heart rate? You want to look at the rhythm. Is it regular or is it irregular? Sometimes some people have a heartbeat. Their pulse will go boom, 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 boom. It's kind of crazy. Strength. Is it real faint? Boom, boom. Or is it bounding? Boom, boom, boom. Those things all tell us different things. You want to look at it, the equality. When you're feeling like both arms or both feet at the same time, the pulses need to be the same on both sides. I like some of these slides. With a pulse. Hang on, let me get to where I want to be in my book. Typical heart rate is what? 60 to 100, right? That's a normal heart rate. Anything lower than 60 is hypo, and anything faster than 100 is hyper. So, one of the things that you will assess is whether someone is tachycardic, which means that they're over 100. Anything slow, the tachy is the word for fast. So anything that's tachy means that it's fast. Brady is the word for slow. So Brady and tachy are opposites. So bradycardia would be a slow heart rate, less than 60. Tachycardia, tachy, that's higher than 100. So if someone has a real low heart rate, they would be considered or low pulse. If it was 55, it'd be bradycardia. If it was 110, it'd be tachycardia. So you want to look at the rate to see if they're tachy or brady, which is our way of talking, tachy or brady. Then you will look at their rhythm. Are they normal or abnormal rhythm? An abnormal rhythm would be dysrhythmia. Dys means it's abnormal. It's irregular. So you could say that they either have a regular rhythm or dysrhythmia. Strength, you want to determine the strength of the pulse. And this is documented in numbers. So a bounding pulse, that would be really just bounding. It would be just like it's jumping out of the skin. That would be a 4. A full or strong pulse is a 3. A normal or expected pulse is a 2. So we typically say like 2 plus. A diminished or barely palpable is a 1, or absent would be 0. So if they have no pulse, you can't find a pulse, it's 0. And then, of course, I said the equality. You want to look at both pulses at the same time, like in the wrists or the feet. The only exception is the pulses, the carotid arteries. You never measure those at the same time because you could actually occlude the artery. And if you're occluding it and you've got both carotid arteries occluded at the same time, you could cause somebody to pass out. So you don't want to do that. So that would be an exception there. Respirations, we count respirations. That's every breath someone takes. So you count their breaths. You basically watch their chest rise and fall. And every time you see it rise, that would be 1. Normal respiration rate is 12 to 20. Anything lower than 12, they're not breathing enough. If they're breathing more than 20, they're breathing too fast. So they're going to be either tachypnic. It's got that tacky word in it. That means they're breathing fast. That's a fun word. I like saying tachypnic. Brady nip. That's not as nice. Bradynia, but it's slow. And then eupnea. EU is like normal. So eupnea is a normal breath. So you want to check their respiratory rate. A lot of times if people know that you're counting their respirations, they subconsciously start breathing faster. So typically what we do is we check people's pulses. We just stay there in that position after we finished counting their pulse, but we stay there a little bit longer and we watch their chest rise and fall and check their respirations, just because we don't really want them to know what we're doing, because otherwise they'll start breathing faster. You have your inspiration, your expiration. Inspiration, breathing in. Expiration, breathing out. You want to look at their depth, their rhythm, their respiratory rates. You want to look at obviously the how many breaths they're taking. Are they taking very shallow breaths? Are they taking deep breaths? The point of breathing is to perfuse your body with oxygen. Perfuse means getting oxygen all throughout your body. You want to stay perfused. We'll say things like, oh, their brain wasn't being perfused. That means their brain's not getting enough oxygen. Different things affect that, obviously. Activity intolerance, hyperventilation. They could have impaired airway, impaired gas exchange. And now we have blood pressure. We check people's blood pressure. That is telling us a lot of different things: the cardiac output, the peripheral resistance, the blood volume, viscosity, elasticity. Blood volume is a big one. A lot of times when somebody's dehydrated, their blood pressure is going to be really low because they don't have enough blood volume. Same thing as if somebody is overly hydrated, they're going to have high blood pressure. They're going to be hypertensive. You could be hypotensive, low blood pressure, or hypertensive, high blood pressure. So obviously, if somebody is hypertensive and they have too much blood volume, the first thing we do is give them a diuretic to diurese them, which means to get the water off. Basically make them pee, and then they have less blood volume, and then their blood pressure should come down. Same thing as somebody's dehydrated and they have their low blood volume and their blood pressure is really low, then we're going to give them fluids. We're going to hang fluids and give them IV fluids and bring their blood pressure up. Different things: age, stress, ethnicity, genetics, gender, meds. Different meds affect it. Your activity and your weight, smoking, hypertension, and hypotension. There's those words. Hyper is high, hypo is low. Your blood pressure cuff. This is you need to make sure you have the correct cuff size. That's a hot button of mine. It seems like the past month or so I've been at a lot of doctor's appointments with different family members, and it seems like everybody's just lazy and they just have the really big cuffs. They just put really the large cuff on everybody. And that's going to give false readings. Matter of fact, if you look at page 519 in the table 29.12, it shows right there. It shows, first of all, the figure 29.9 shows how the cuff should be positioned. 20% more than the upper arm diameter, or 40% of circumference, 2/3 of the arm. So it shows the proper placement. And it shows if you have the cuff, the blood pressure cuff is too wide, you're going to have a false low reading. Or if it's too narrow or too short, again, false high reading. The cuff could be wrapped too loosely, it's going to be a false high reading. So look at all of these. Look at this table 29.12 on page 519. If you don't, blood pressure seems like it's pretty simple, but look, arm below heart level, it's going to be false high. Above heart level, it's low. Arm not supported, false high. Inflating the cuff too slowly, a false high. If you repeat it too quickly, false high. That means if you check the blood pressure and they go, oh, didn't quite get it, let me pump it back up and do it again. It's going to be higher the second time. So there's a lot of different parts of that, but it's very important. Have the correct equipment, correct cuff size, and just pay attention to these different things because this could be, well, just an example. Doctor's office with my mom. My mom's 93 years old. She's, small. She's only 5 foot tall anyway. And then they put this huge giant blood pressure cuff on her that's made for probably a 300-pound man. And I knew that this was going to, now it says cuff too large could be a low reading, but I don't know, whatever they did, but they came back with a blood pressure reading that was ridiculously high. It was like, oh, your blood pressure is 210 over 120. Well, my mother does not have a blood pressure that high. And I knew that the blood pressure cuff and just the whole process, the way they did it was wrong. And I was like, no. That's like, you need to do that again with a different blood pressure cuff. And they did. And then, oh, miraculously, her blood pressure was just perfect. It was like, 120 over 80. So, they could have really caused a crisis and a potential problem that was just for their own ineptness. Orthostatic hypotension. Orthostatic hypotension. So we know hypo is low, so that's a low blood pressure. Orthostatic. That is people, if you stand up, and it's a difference in the blood pressure when somebody stands up like really fast. I don't know if any of y'all ever had that happen where you stand up really fast and all of a sudden it's like, woo, all of a sudden you feel dizzy or maybe even go black a little bit. That's orthostatic hypotension. I'm not real sure why they have that listed on here, but it's here, so I told you what it is. Now, the other part of the slide is carotid cuff phases, and these are different sounds you hear when you take blood pressure. Your carotid cuff, and I don't know if I'm saying that right, but these are different sounds that you'll hear when you're taking a blood pressure, and you can see here what the first sound you hear is a sharp thump. So you'll listen when we're practicing in the lab. You'll see what I'm talking about. You hear this loud thump. And then you'll hear like a blowing, and then you'll hear a little tap, 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 and then you'll hear the blowing, and then it stops. Those are the different phases, and that's what they're called, the carotid cuff phases. When we're in lab, we'll practice that, and you'll see what that is all about. There's a blood pressure machine. Okay. Blood pressure, you can do blood pressures in lower extremities on some people. Some people, you can't take it in the arm. You'll have to use the legs. You can do that. Talking about children, just have to make sure you have the right cuff. Sometimes it can be challenging if they're wiggling around, moving, fidgeting, because you're not going to get an accurate pressure. Self-measurement, a lot of people, pretty much everybody that has hypertension and takes blood pressure medication, they monitor their blood pressure at home. Usually they keep a log. It's nice. They have those automated ones. They have even some that are on the cuff, even though those aren't supposed to be as accurate. Different things again that affect your blood pressure. Didn't we talk about this? Anxiety, fluid imbalance. All right, safety guidelines. Make sure you clean your devices between patients so you can decrease the risk of transmitting infection. Rotate sites during repeated measurements of blood pressure. So if you take a blood pressure on one arm and something, it's either just doesn't seem right or maybe it just didn't something, and you have to take the blood pressure again, you need to switch to the other arm. You don't want to keep doing repeated measurements in the same place. Determine a patient's status before delegating a vital sign skill. Yeah, definitely you need to make that, that's a critical decision. You don't want to just delegate somebody else to check a vital sign that you believe may be possibly even life-threatening. Pulse ox, we didn't even talk about pulse oximetry here, but the pulse ox determines how much oxygen is in their blood, and if you know somebody's having issues with their respirations, and you don't necessarily want to tell a CNA, hey, go check their their oxygen levels, go do their their pulse ox, because it could be 85 and CNA may be busy doing something else and don't they may not come back and report that to you immediately, and that's pretty an urgent situation. That patient's going to need some oxygen ASAP. So in a situation where you anticipate that it could be an abnormality or something that may need an intervention, you just need to just do it yourself. Alrighty, any questions? Let me know.